All right, so here's EMT Case 6. Same prereqs as we've had for a while. Make sure you can find your way and do all that part. When you're working as the partner of a paramedic on an ALS ambulance crew, it's really important that you be able to do all of these things at a very high level and pull your weight as a member of that partnership. Also prereqs, including the basics of assessment, CVO, HPI, and then be aware of causes of a patient having a fall. And be aware that the cause of that fall is in many cases just as serious or more serious than the injuries that they sustain from the fall. People don't fall just because they trip on their feet. It can also be a cardiac or neuro event that causes it. You should be aware of the various causes of altered mental status, and there are numerous, probably a dozen, depending on how you list them. Be able to manage injuries and be able to manage some of those causes of altered mental status. And then be aware of the impact of prescription medications. There's no way you're going to know what every medicine is for. In some cases, it's appropriate to look them up, but just be aware that many patients take prescription medications to prevent cardiovascular disasters like heart attack and stroke. And those medications do a good job of preventing those problems, but when they do have a fall or have some trauma of some other cause, then those medicines may actually be working against them in a trauma situation. So the time of the day on this one is important. The day of the week is not necessarily important, but we're going to say that you're called at 2100 hours, so 9 p.m. You have a 5-minute response time. The transporting ALS unit is 5 minutes behind. You are a BLS first response unit, and your hospitals are really pretty close. There's a couple of ERs not too far away. The trauma center is actually the closest place. Whether your patient needs a trauma center or not, no one knows. But that's the that's the system info. You're dispatched to a Bravo response for a fall, so not predicted to be high acuity. And the address is a senior apartment complex. Now, this is independent living, senior apartments. There are no medical staff on site. The cross streets Granada and Diego Court. Lights and siren are probably indicated. It's a short response, easy routing normally. You should at least have an urgent response to this. If you elect to not use lights and siren, that's an okay judgment call based on light traffic and such. But you should, move urgently and get right over to the scene here. On the way, you're thinking, well, a fall could have injuries from the fall, but then the cause of the fall can also be a big deal, so I should investigate that. And when you hear a fall at a senior independent living apartment complex, you've got to be thinking hip. And some of those can produce some internal bleeding, but those patients with long bone fractures are usually, they fall and then they call, and any bleeding from those injuries doesn't end up being a big deal unless we have a really long transport time, or if we don't find them until well after they fell. And then probably no big safety issues at the senior independent living home. Here's the complex, real nice place. Nice big circle drive off major streets. As long as you can get in the door after hours, everything's good. Problem is you can't always get in the door after hours, and so then that would give us a chance to talk about, unless someone meets you there from family, how are you going to get in? Gives us a chance to talk about Knox box and how that goes. And so your coaches can talk about that, and the fire people in your EMT class should be able to clue you in if you're not clear on the Knox box system. In this case, the son-in-law meets you, says he hasn't heard from her all day. This is his mother-in-law. She always showers every morning. I wish I'd come over sooner. She's probably been here all day. So he pretty much tees it up for you, if you'll listen to him, if you'll pay attention to him, that she has probably fallen and she's probably been down all day. When you find her, she's covered up with some towels. She's on her right side in the bathroom just outside the shower. Very clear that she was taking a shower and she fell, either out of the shower or fell as she was getting out. She's alert. She's oriented to her name and her age. She doesn't know what day of the week it is, what date, or even what year it is. Doesn't know for sure where she is. Her radial pulse is weak, but at normal rate. Skin's cool, pale, and moist. Breathing's a little bit fast. Labored and shallow. No cyanosis. So you move on. Are there any urgent actions here? Well, what's going on with the breathing? You need to figure that out. That didn't really fit what you were expecting. And then could she be in shock? Well, I guess. I mean, it could be that she has broken bones that have been bleeding internally for a number of hours. And then, what about that confusion? Is that normal for her? Some patients that live in those places or assisted living have no idea what day of the week it is normally. But they would know where they are, and they would know probably the year, and things like that. A lot of people like to ask who the president is. I don't know if that really makes any difference or not. But you're looking for what is her normal, what is her baseline mental state? And then assess for and rule out other causes of altered mental status. So you should not assume that because she's a little confused, it's because she fell and hit her head or something. We need to rule out all the causes of altered mental status. Going to gather some data and info. BP is 90/30, heart rate 120, weak and irregularly irregular, meaning there's no pattern to it. A regular irregularity would mean that it goes beat, beat, pause, or beat, 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 pause, or something. So there is a pattern that repeats. But in this case, it's just all over the place. And that's not uncommon at all for elderly patients. It indicates most likely atrial fibrillation, which is a common cardiac rhythm problem that a whole bunch of old folks have. She's breathing 20-24 a minute, not real deep. Says it hurts when she takes a deep breath, so we need to further figure out what that's all about. And her pulse ox is only reading 91%. So another indicator that something's going on. So what's her baseline? Well, she's pretty healthy, takes her meds for high blood pressure, does some exercise with the ladies group at the complex. She's pretty active. She moves, she drives. She pretty much does her own thing. She's got a few short-term memory issues, but there's in no case is she incompetent. She can make her own decisions. She just may not remember what she ate for breakfast this morning or something. What about her O2 therapy? Well, she doesn't have any known lung disease. She's breathing with some difficulty and shallow, and her pulse ox reads 91, and she's confused. And so it's at least 4 liters per minute with a cannula, and then see if things get a little bit better. And if you went to a non-rebreather mask, it's not wrong. You're probably okay with 4 liters with a cannula for a few minutes and reassess. And if it's not coming up, you're going to move to a non-rebreather anyway. History of present events, she has no idea what happened. The family says she showers every morning. She clearly was in the process of doing that, but she doesn't know if she was done. She doesn't know if she fell. She doesn't know if she had chest pain or a headache, doesn't know. But given the current time and using the bystander information and thinking, it seems reasonable to figure out that she's been down all day. What about her meds? Well, there's a list of medicines that you can see, and they include metoprolol and something called HCTZ and lisinopril. And then she also takes an aspirin every day, and she takes a sleeping pill, which is Ambien, and she takes tramadol for arthritis, And this is not made up. These are actual meds from an actual patient who's fairly typical of this situation. It's actually my wife's grandmother when she lived at that place. So none of this is made up at all. She has no cardiac history, no diabetes, no strokes. She has a lot of arthritis in her knees and her shoulder. And so you could look up what those meds are for. And it might be, if you have 2 or 3 folks there to help you, that you would task somebody with look these up on your phone, or some other way to find out what those medicines are for. But right now you're just kind of gathering the information. So you say, well, take a deep breath, and it hurts a lot worse. The pain is reproducible, and it is pleuritic. So now we're thinking that chest wall motion is the issue. She's tender over the right axilla. You can't really see it without moving her, and she doesn't want you to move her. It hurts a lot for her to move at all. That's why she hasn't gotten up on her own. Isn't that she couldn't, it's that it hurt too much for her to. Lungs are clear in the upper fields and left base, but it's diminished in that right base where she's injured. So now you're going back in your mind real quick to, oh my, is this a flail? Is this a contusion? Is this a hemo or a hemopneumo or a simple pneumo, or what is this? She's got pain in her right upper arm and pain in her right hip. You check her pupils right quick, and they're 6 or 7 millimeters, so you should know what that means and how to gauge those. And one of the best references on the side of your pen light, but 6 to 7 is pretty much mid-range. It's not really tiny and it's not really huge. They are equal. They are round and they react. Her glucose is 88. So you're kind of working down a list of altered mental status causes, and you're using your physical exam to help you get through that list. And you repeat those vitals. Looks like the pulse ox has come up a little bit, 2 or 3 points. So we're going to stick with that. If you'd gone with non-rebreather, it probably would have come up a little bit more, but still, you're heading in the right direction, and that cannula is much more comfortable for her. The medics walk in. You say, this is Mrs. Smith. She's 85. We think she fell in the shower and has been down all day. You got to lead with that. That's the important thing. That should clue the medics into what's going on. She's got a right arm injury. Her chest and hip are very painful. Here's her current vitals. Her glucose is okay. Inbound report would look like that. You can pause if you want to read it. Handoff to the ER would look like that. Again, you can pause if you want to read it. It would be reasonable for you to know a few medicines, a few things about patients' prescription meds. And so the metoprolol and lisinopril, those are very common, as is Ambien, as is tramadol. These are all very common meds. And so maybe you, if you don't know by this point, when you give your hand off to the ER, that might be time where you could interact with somebody from the ER who could educate you a little bit for your next call. And then you think about, what all went on here, and, did this lady have an MI, or what other causes were there for her chest pain? Here would be your first responder report. And then your video debrief. Same as usual. Here's some questions to kind of wrap this case up. Why was her pulse rate irregularly irregular? We talked a little bit about atrial fib. Does this impact your assessment of the severity? Probably not. Coaches can talk to you about this a little bit in debrief of the case. Why were the lung sounds diminished? What could cause that? What are all the causes of altered mental status? All very important things. What about those meds? What is metoprolol? What is a medicine that ends in OLOL? What does that do for a patient? And then, what are those other meds and what are they for? And then some what ifs. What would you have done if her glucose was low? What would you have done if her pulse ox was 85 instead of 91? I think you'd have gone right to the non-rebreather there, right? What would you have done if her pulse ox didn't increase? What would you have thought if her pupils had been tiny? So there's lots of options and questions and various discussion points that you can use on this. And so we'll let you experience case 6 in lab.